Hello and welcome to Daisy Hill Emergency Medicine Teaching. This is Ashley Craig, your host. I'm going to talk today about geriatric trauma. So we're going to give an oversight of trauma in the elderly population, why it's different to trauma in the young population, and go over a few do's and don'ts and some of the ABCs of trauma care in the elderly. So, start, aging as a process is defined as the normal, predictable and irreversible changes of organ systems over the passage of time, ultimately leading to death. And how that occurs on a microscopic level, obviously you've got telomeres, and you just lose function over time. You get senescence of cells, reduced responsiveness of tissues and organs, and a reduced response to threat. As you get older, performance reduces, obviously, and so that's why we tend not to see massive numbers of 70-year-olds at the Olympics. But somebody's clearly racing them out there. I don't really know what's going on there, to be perfectly honest with you, but certainly there's records to be had if you're old. Can't wait. So take the heart as an example of reduced responsiveness over time. You tend to find that there's obviously reduced elasticity, reduced contractility, so your cardiac output tends to reduce and tends to get worse as you get older, and that's got big implications if your cardiac output suddenly has to go up higher in response to bleeding and trauma, or if you get, say, pneumothorax and you can't fill your heart. It has massive issues. As you get older, you tend to develop these accessories, so be that walking aids or hearing aids or glasses, or reduced sight, reduced proprioception, reduced ability to respond, and reduced sort of response time generally. So you tend to find that you get a particular type of fall where you're not able to roll up in a ball or put your hands out in front of you. You tend to get a lot more head injuries as a result of that, rather. The problem's only going to get bigger, or so get used to it. Increased lifespan means that we're going to be seeing massive numbers of old people as we get older as doctors ourselves. So the projected UN numbers are that 2.5 billion of the world's population will be over 65 by 2050. Which will be about 20% of the population overall. At the moment, trauma is about the 7th biggest cause of death in the elderly, and so it's worth knowing a wee bit about it. Numbers would tell us that overall you're less likely to be injured than if you're a young person, and that's mainly because of reduced snowboarding and reduced skateboarding and bodyboarding and surfboarding. But just basically whatever activities are much less likely to be high risk. But unfortunately, you're much more likely to suffer fatality from your injuries whenever you do get them. And the mortality spikes up the more pre-existing diseases that you have. And the big hitters when it comes to proportions of injuries come from falls, followed by RTCs, followed by burns. And in Daisy Hill, somewhere in between RTCs and burns would probably put farm incidents, because there's an awful lot of elderly gentlemen out there working farms at the moment in the countryside around Uri. But focusing on falls make up about 40% of elderly trauma deaths overall. And obviously, as you'd expect, the incidence and severity of complications goes up with age, but I think about 10% roughly will cause serious injury, and the other ones, if they're not able to get up and go with a bit of GLT care, will be coming into hospital to see why they can't get up and go. But it's massive numbers overall. We see loads and loads and loads of elderly falls. RTCs, again, response time, ability to see, ability to not have a heart attack behind the wheel, ability to not have a stroke behind the wheel. means that you do see more RTCs in elderly folks proportionally than middle-aged, but obviously less than really young teenagers and boy racers. Fires are very often fatal in elderly folks, and that's typically because they're not able to respond to the threat and get themselves out of harm's way. So you'll tend to find that if there's a fire in a house and there's nobody else in the house that can raise the alarm, very often you will have deaths in house fires. So going through the ABCs, starting with the airway. Obviously think oxygen. Your approach, you need to be prepared to make an early decision in regards to intubation, because you may not have as much time as you think with some of these patients. Really, because, as I'll repeat to the point of absurdity, they do not compensate very well for any problem that you might present them with. So think about involving an anaesthetist early if you do identify an airway issue. So it's not an exhaustive list, but beware of patients with false teeth. Beware of the faceplant who's broken everything. Beware of big tongues and small mouths and necks that just don't move because of fixed flexion deformities and fused vertebrae and just arthritis generally. So no teeth. Obviously that can play into your hands if you're putting a tube in, but if you're trying to bag a patient or put a face mask on just to give them a bit of CPAP, sometimes it can present a bit of a challenge. But overall, if the patient's got no teeth, the main thing you should be asking is where are their false teeth, because they may well be down in the oropharynx. Big tongues don't make it any easier to do anything in the mouth or the airway. So your amyloids and your your mixed edema patients. Microstomias, small mouths, small reduced mouth opening. TMJ arthritis can make it very, very difficult to get any form of airway in. And then we move on to neck stuff and immobile necks and necks that are fragile and break at the moment's notice if you overextend them. That's obviously a big consideration. So moving back, that's a chalk stick fracture of C6, I think, where it's just a hyperextension injury from a faceplant. But obviously that, if you go to hyperextend that neck to put a tube in, you're going to have a bad time. We see quite a lot of laryngeal injuries for some reason. It's quite common because the larynx being a exposed area, it's quite common for patients to fall and hit the larynx. And really, whenever you're older, everything calcifies, so your larynx is no different to that. It just becomes a calcified ring which will break and either bleed or cause surgical emphysema. So if you see bruising in the neck or a tender neck at the front, it's worth considering getting an anaesthetist down quite sharply, because we can see these can escalate quite dramatically. So if you look at this patient, they've got a hematoma anteriorly and somebody's put a tube in and there's a fracture in their larynx, and that's quite a similar thing there with surgical emphysema visible anteriorly. Moving on, breathing and ventilation, which is what comes next. So as you get older, you've got reduced respiratory reserve, so obviously intervene with oxygen, but do monitor that and be aware that you're a bit more likely to cause oxygen toxicity and hypoxemia So monitoring, if a patient who's elderly needs oxygen, they get all of the monitors. Chest wall injuries are poorly tolerated in this population, so analgesia to improve their ability to move, and monitoring so that they don't get so they don't stop breathing, and be very cautious with your IV fluids if you've got a patient with failure, because you don't want to really compound the problems. A couple of injury patterns, probably more than the three that are suggested here. If you're young, at the top, you'll tend to find that if you've got significant trauma from the side, you'll get contusions to the lungs, but your ribs might not necessarily break. Whereas if you're old, you'll definitely get the contusions, but you'll get broken ribs as well in a flail segment pattern, and your patient will have a bad time. Coming from the front, it's quite common to see bilateral rib fractures on both sides, so occasionally a bilateral flail segments can develop, and again, that is not great. So just go over a wee bit about chest x-rays. Chest x-rays can be very deceptive. It's worth having a system. If you're on the floor and we're interpreting x-rays, we will usually show you the way it's taught on the ATLS, where you physically turn the x-ray onto the side, and then you're able to count the ribs and work along each rib so that you can identify not only how many ribs are broken, but which ribs and where, and how many fractures in each rib there are. In general, your chest x-rays are, not as good as a CT. So if you've got somebody who's unstable, it is not a substitute for that. But at a minimum, if a person who is over 65 is tender in an area after a fall, you need to get a plain film, if not a CT. So airway bones, cardiac, diaphragm, effusions, foreign bodies, gastric hilum, as you've been taught from medical school. But if I present you with this x-ray, you can see that there's something bad going on in the left-hand side of that person's chest. But if you're just looking at the x-ray from straight on, you will find that it is difficult to know exactly which ribs are broke quickly. So if you turn it on its side and you pause this, you'll find that it is a lot easier to actually identify which ribs are broken, and you'll find that this person's actually broken about 6 ribs in that left side. That's just a diagram, sorry. So flail segment, quite common in that sort of scenario. Basically your seesaw movement of the right hand side of this person's chest, so that whenever they try to inspire, they just draw air across from the broken side, and whenever they try to expire, they just inflate the broken side. That moves paradoxically. So as a result, the patient can become quite hypoxic and quite sick, and usually that would go to intensive care. So this is another case just to show a different injury pattern. This is a head-on collision, seat-belted man who's basically got a sore chest. So you decide to, he looks stable, I'm going to do a chest x-ray and see if there's anything there. And that looks pretty normal, unfortunately, so you haven't really found an answer. And the reason that you haven't found an answer is you fail to consider the sternum as a problem. So this person's sternum is actually overlapping. So again, that would need CT'd, and usually, if not ICU, then coronary care if there's significant injury, or the surgical ward with PCA. This is just a note so that you're aware that tension pneumothoraces do occur in the elderly, and from the point of view of not considering it, if you don't consider it, you'll not see it. They don't tolerate these very well, because really anything that puts up the pressure inside the chest, you will not be able to get any preload going at all in your heart, and your cardiac output will tank. So again, same rules as always. If you need to decompress a chest, you can do it urgently with a chest drain, or emergently if they're arrested with finger thoracostomies. But don't do nothing, because that isn't an option. Circulation, as we've commented loads and loads of times so far, there is reduced cardiac function with age, and you get this diastolic dysfunction where your heart just is not elastic and doesn't respond to increased thoracic pressure very well. Tend to find that you're more likely to have a dysrhythmia, so your heart, may not be able to respond because of antiarrhythmics that are on board. You may find that there's sick sinus, so you just do not get a tachy under any circumstances, or a pacemaker where you cannot make a tachycardia happen. And your normal blood pressure of 110/70 may be vastly different from the patient's normal blood pressure of 200/100, which is what loads and loads and loads of elderly folk are walking around with. So monitoring is important. All of the monitors and serial obs, and it's not enough to just look at numbers. Look at numbers and think if they're appropriate, and if a person looks white as a sheet but has a blood pressure of 110/70, ask yourself, well, what is it normally? Because that's a bit, everything else looks like a sick person, so it's just common sense. Hemorrhage is about 30 to 40% of early trauma deaths, and it's the same in the elderly folk. The elderly folks have a reputation for being as tough as boots, and will embarrass you every time and hide their bleeding in really surprising ways. So think retroperitoneum, think pelvis, think abdominal cavity, think acetabular fractures, think pubic rami fractures, think unstable pelvic fractures. And the best thing that you can do is to recognize it early. So if you cannot recognize something, if you don't suspect it, so have a low suspicion, or high degree of suspicion. Forget what way that goes, but either way, suspect everyone, and recognize bleeding, and then control it and restore the volume. We're big fans of you controlling bleeding. It's definitely a good thing, and something that you should aim to do whatever stage you're at as a doctor. So obviously there's frequently an operation to be done. More commonly these days, if you've got an organ bleeding inside you, they may opt to do a intervention radiology approach and embolize or coil the bleeding vessels, and that's definitely a good thing, although the actual access to that type of intervention is limited. So ultimately it's whatever works and whatever is best for the patient, but do not let a patient continue to be acidotic and hypotensive. It's not really an acceptable approach, so do something. So stop the bleeding, look for those patients that are at risk of coagulopathy and bleeding, treat the bleeding and the coagulopathy. So big fans of things that carry oxygen, big fans of things that make clots happen. So if you need to give bleeding, if you need to give blood, that's usually indicated. And if you need to give them TXA and FFP, that's also usually a good idea if the alternative is getting worse. So put them in a position where you can observe the response, and that's high dependency at a minimum, or theatre, or ICU, and be in a position where you can prevent secondary bleeding, so hence surgical access, trauma units, etc. So trauma team recommendations: use lactate to estimate if there's shock, use whole body CT where the GCS is less than 14, systolic blood pressure less than 90 and respiratory rates less than 10 or greater than 30, or significant mechanism. And mechanisms are a little bit more, a little bit less significant when it comes to elderly folks. So, you know, although you've got motor vehicles obviously with greater than 50%, 50 mile an hour speeds combined, and pedestrians over 30 mile an hour speeds, you can have, there's no reason that you can't have a fender bender and come in with a flail chest if you're elderly. So it really just depends on the patient. Entrapment, obviously, forgot to say earlier when it comes to RTCs, but one of the main reasons that elderly folks die in RTCs is because they cannot get themselves out of their own car. But basically these are the rules for any trauma team activation, and they apply just as much to the elderly. So fall greater than 2 meters, that's a fall downstairs, and that's the commonest type of activation that we'd have for the trauma team. Recommendations are the same as for the rest of the population. So if you are unable to actually do anything right away and you're able to get them to theatre, you are allowed to do permissive hypotension, where you try and avoid pinging off a clot, which is stopping you from actually bleeding out, and maintain a blood pressure about 80 to 90 with blood and bleeding and products. So basically low volume recess, survival's better, and no such thing as routine fluid in the elderly trauma patient. Intra-abdominal bleeding can occur. In this case it's a liver bleed, liver capsular bleed, and in this case it's another liver capsular bleed again. In this case it's a splenic bleed. You can see over on the left side of the right side of the image. It's just to show you that interventional radiology is a thing, and for an isolated injury like that, ideally you'd like the patient to not have to have a laparotomy if they're of a certain age, and doing an intervention and embolizing the spleen would probably be a nicer approach. And same goes for the kidney there, where somebody's putting a catheter in and identifying the bleeding point and then embolizing. That's a broken acetabulum, and it's just to there to remind me to tell you to think about retroperitoneal bleeds and pelvic bleeds, which can occur and are extremely embarrassing if you miss them. So loads and loads and loads of vessels adjacent to the pubic bones and the pelvic bones, and broken pelvises that are unstable, pelvic binders obviously, but very hard to think about that whenever you've got a patient that's only fallen from standing height. So recognizing that type of bleed, it's extremely hard, and but do have a low threshold for CT if you suspect that. So moving on to the brain. Obviously if you fall over and hit your head and you've got a certain amount of space inside your skull vault, you don't necessarily present right away with a subdural. So very frequently there's a gradual decline seen, or a severe headache or confusion. So there's a lot of subacute presentations with subdurals. Overall contusional injuries are less common because of the fact that you've got more space inside your skull for the brain to bump around. But if you've got a patient with a headache after minor falls a couple of weeks before, have a low threshold for CT in the head at that age, because you will find things quite commonly. And while aspirin itself is a fairly low chance of causing a subdural, it doesn't make it less likely. And even though we're very geared up to look for with relatively minor head injuries to look for subdurals on folks who are on apixaban and warfarin. It's still quite feasible to have a subdural without any provocation or any anticoagulant at all. So just maintain a fairly open mind when it comes to this, and have a degree of suspicion just to pick those up. Some pretty pictures. That's an acute bleed with the bright white blood on the left side, and then this is what we more commonly see, which is acute on chronic, and these sort of laminations, different ages of blood, and fresh blood up at the top, and then at the bottom sort of old altered blood. And you can clearly see that that's a sequence of images over time which show the same patient, and obviously a lot of midline shifts developed as they've continued to bleed and the swelling's developed. So obviously talk to neurosurgeons about these injuries, get a plan, document it, admit them locally is generally the advice if it's a small bleed. So just to move on to assessing the C-spine. The main rules that we have with regards to imaging are taken directly from the NICE guidelines. So please do not image serious mechanisms of injury at this age with plain film C-spine films. You will miss fractures, you'll miss significant pathology, and the reason that NICE guidelines have specify C-spine CT for the over 65 population is because of the difficulty in interpreting images, and because of, frankly, the really high likelihood that if somebody has fallen down the stairs aged 80, that they will have broken their peg. It just seems to happen again and again and again. Either way, injury is more common than with the younger folks. The main difficulty is that the neurological injuries are also more common and more likely because of reduced space, because of stenosis. So these are just a few images for something to look at, but typically compression fractures obviously are quite common. Peg fractures also common. That's a plain film on an older gent. Very difficult to actually see the line through the peg. You don't really see it unless you're actually looking for it. But that's I think a type 2 peg fracture, and that's how it usually looks on CT. And that's type 3 peg fracture. You can obviously go and have a look, do your radiopedia sessions, and look elsewhere for a full and intimate takedown on C-spine injuries. That's another wedge compression fracture again. It's interesting, it's easy to see on the CT, so whereas plain films, you could kind of persuade yourself that there was nothing there, but actually there's quite a significant loss of height, and those are a few teardrop fractures. So all I can say is that if you've got any form of neurology after a significant injury like that, please use cross-sectional imaging before you consider taking them out of a collar. Do not do anything on the basis of plain films if there's actual neurology. This is just an image that highlights, let's say, the need to be quick whenever we're seeing and assessing trauma stuff. That's a pressure sore, and it's occurred because somebody has lain on a old school trauma board, which are now not in use, but the principles are the same. You want to get as much information as you can, as quickly as you can for these patients, so that if you're able to move them off their hard mattress as quickly as you can. So it used to be really, really common to see these sorts of injuries in ICU, where you would have occipital pressure sores because people weren't able to be brought out of their immobilization quick enough. So obviously there's a trade-off there if you've got a significant neurological defect, but if you're just having a patient sitting for hours waiting for the results of CT and potentially getting them a pressure sore injury, then there's something wrong. Similarly, your collars. This is again a pressure injury on a neck. You can see that quite deep tissues have been necrosed and eaten away at there, and that's purely from having a hard collar on for ages. So as soon as you can get an opportunity, your earliest opportunity rather, please put your patient into an aspirin collar. It's much more comfortable at that age, and it's moldable to their neck shape. Forget that half of these patients are really kyphosed, have an unusual necks at baseline, and don't just neatly fit onto a trauma mattress. So be prepared to use pillows and ramps and so on to actually make their lie comfortable and anatomically correct, even if the CT has to work around them. Do not tape them down to the mattress if they've got a severe fixed flexion deformity. So those are out. Then you need to step back and ask the obvious questions, like why did this person fall or crash their car or get involved in a burn. You need to look for sepsis and treat it. You need to look for strokes and identify it. You need to look for the obvious sepsises like ETIs and pneumonias. And obviously they may have had a secondary injury on their journey to you. They may have been lying for 24 hours on a hard kitchen floor, getting muscle injury and hypothermic. So those are special areas of concern when it comes to the elderly. Have a look at their medications and x-ray literally anything that is tender. Elder abuse is a real thing. It can be really subtle, and it does follow the same rough types of patterns as you would see in toddlers and young folk. So getting into any of these 6 categories, so physical, sexual, neglect, psychological, financial, violation of rights. And the findings are pretty much the same in terms of what you look for. So contusions in areas that should not be contused, ligature marks, oral injuries without face planting, untreated pressure sores, and untreated fractures, injuries of various ages, and contact burns. The biggest clue, similarly to your children, is next of kins or relatives who don't really have an emotional response to your findings, don't really seem to think that this is a big deal. It should raise your spider sense and make you want to know more. So if you do suspect it, don't stop until you're satisfied, and do escalate your concerns. And obviously your chance of dying is quite high with elderly trauma cases, and your chances of being improving their survival, of being able to improve their survival rather, is also quite good, but it does need you to step in early with resus and put them under the lens and really treat them with a high degree of suspicion. But even with that, there will be cases that just are not survivable, usually neurological, but obviously burns, from the point of view of burns, as we've mentioned before. If you have over 50% burns at the age of 70, it's very, very common, although they may go to intensive care. It may follow a palliative course, depending on how they do, and the mortality rate the books would tell us that would approach 100% in those sort of circumstances. So obviously that's something to be borne in mind, and do advanced planning and make some early decisions in regards to destination from a ward point of view, so that you can get them to a position where they don't necessarily have to die in a treatment room down in ED. So in summarization, or as a summary, or in conclusion, my concluding remarks are, please use the CT for heads, necks and anyone unstable. Please expect a difficult airway, and please ensure that your patient gets analgesia early, gets an appropriate level of monitoring for any chest wall injuries. And obviously early intervention is usually preferable to conservative management in hemorrhage. So be prepared to make lots of phone calls and involve the surgeons and involve anaesthetists. And basically these patients are occasionally the sickest patient in the building, so you should generally act like that and make a big deal of them. So that's elderly trauma.